Good morning, everybody. It's my pleasure to be here today. Um, uh, as the title implies, this is actually going to be some sort of a practical issue, tips and tricks, more than jargon of data. So I'll just try to be like go over the practical things very quickly. Why we are facing more calcifications, because we have all the risk factors for that being very common in our part of the world: diabetes, CKD, longer life expectancy. That would make you face much of the and I've seen, compared to my fellowship in the States, a lot of more severely calcified vessels in our region. Why? And because we have, as you know, more uh, risk factors for that. So just we need to know that the calcification increase the risk of under-expansion, edge dissection, restenosis, and stent thrombosis. So there is multiple expert recommendation that actually recommend active calcium modification. Again, using an intravascular imaging also would increase the gain of your detection and give you exactly what is your calcium morphology in the vessel. I'm going to leave this for the people doing intravascular ultrasound in this session after a few minutes. My approach to do calcified vessels, I mean, unless it is an ACS or acute STEMI or non-STEMI, I wouldn't actually do calcified lesion unless I have enough time on my hand. I do meticulous planning. I usually like to have like a very good support of a guide, planning to do guideliner, usually larger French sheet and guide. Then we'll upscale our arsenal in a stepwise approach. So starting with a balloon, regular, compliant balloon, short, going up to more compliant type of balloon, and then escalate our equipment accordingly. If nothing crosses, just I will go to the our big gun, which is the rotablation. So what do we have available? Debulking technologies, as you know, all compliant, non-compliant, high-pressure balloons, cutting balloons, lithotripsy, rotational atherectomy, rotablation, and sometimes excimer laser can be used. I'll just go over just some of those as they are more commonly used, which is cutting balloons, pros, controlled, so you can have predictable, controlled modification of the vessel. The blades or the microtomes create longitudinal incisions in the fibrous calcified tissue and reduces the dog boning of the stent. It has a lower inflation pressure. It's helpful in eccentric calcification, fibrotic non-circumferential calcification, and treatment of ISR, as well as treating aorto-ostial lesions when NC balloons might be dangerous. What's the cause of using the balloon? Limited efficiency, in heavy circumferential calcium, high risk of dissection and perforation compared to the NC balloon, for example, and then thicker crossing profile limited balloon sizes and length, and not a standalone device. Lithotripsy is actually making like a revolution in the technology of calcium debulking. It is easy, safe, can treat deep circumferential calcium with an arc more than 180 and a thickness more than 0.5 millimeters. It's a low risk of dissection perforation, as we said, familiar for everybody. So it can be used in non-specialized, non-expert setting. It works with wide ranges of sizes, and it's uniquely effective in treatment under expanded stents, which is a very unique indication. When you put a stent, you don't recognize the how much calcium in the vessel, and then you find out that your stent is not expanding. So you go with your, and it happened several times. Whatever you do, high pressure, non-compliant, the stent will not expand. If you use the lithotripsy balloon, it will actually most of the time help you in this situation. So what is the cons of the lithotripsy? It has large crossing profile, limited balloon size, significantly more expensive than our regular balloons, less effective in eccentric calcium, and requires balloon inflation during shock, which actually can be sometimes troublesome, especially if you are doing left main or high sensitive bifurcation disease. Our best, I think, technology available is both rotablator and the rotational atherectomy. It crosses when nothing would cross. The burr actually does differentially cuts the calcium and spare the soft tissue. So it is theoretically should not cause trouble, but sometimes it does. Effective in eccentric, nodular, and diffuse calcium, osteal lesions, and tortuous vessels. Durable, well-studied technology. However, there is a high risk of no reflow because of all the calcium debris that you actually shave off the lesions. You can get a lot of deposits distally, and distal embolization of small particles that will give you no reflow. Requires more seasoned operators, so it's difficult to start all of a sudden in a place where you don't have that much of experience. And there is risk of burr entrapment, and this is actually one of the very if it happened or you see it in front of you, it's going to be like really the only way to do it is actually taking the patient to surgery, because if the burr does get trapped inside the vessel and it wouldn't retract, then and there is a lot of tricks to try to get it out, but again, we should be. I mean, this is one of the things that you need to be very aware of. Cannot treat deep calcium. There's a risk of perforation and dissection, and you need to exchange your regular wire that you crossed with a rota wire, as we all know. Cannot treat instant and under expansion, and actually it might be dangerous in using it with the stented segments, and cannot theoretically be used in a balloon dissected lesion. So I'll just go ahead and show you just a quick case here. 85 years old lady, diabetes, hypertension, dyslipidemia. She's limited mobility. CKD, GFR of 14, presented with non-STEMI troponin of 6,000, EF 40%. Echo showed anterior wall hypokinesis. She was discussed in our combined meeting for possible, she was cath first, and that cath showed 3 vessel disease, discussed, and she was not offered surgery, so I was contacted to see her and try to help. As you can see here, that there is severe calcification with very 90-degree angle, which is very difficult was even to wire. So I'm gonna give you from the other view. So this is actually a 0.75 balloon, which is the smallest we can get, and you can see it's just like I couldn't even let it nudge or move. So I'm not sure why it jumped, but anyway, there is here the, I would direct, because nothing was able to pass, I went directly to rotablation. You can see that at first, actually, if I can, is there a pointer here? You can see that the calcium nodule very clear in the image. You can see it in the mid of that vessel, and it's preventing anything to pass. Anyway, at the end, I was lucky enough to get the rotablation or rotablator to pass the around the corner, and then we went with the high pressure. Okay. Sorry. Can I just 2 minutes? Please, just to finish the case.
Sure.
Okay.
Can you give him, please?
Come. Right. So this is the final picture. As you can see, there is the stent is very well expanded, and I was able to get around it very quickly. I'll just go quickly on this. You can see that here that we say in Arabic, الجواب باين من عنوانه. So you can see here how much calcification and tortuosity in that femoral artery. This is just quickly another patient had a diagnostic cath that showed severe 3-vessel disease, and the best vessel that has especially diffuse vessel disease. I'll just go here, and as you can see here, I'm going femoral. I'm using TPM because in non-flow of the RCA, you can get severe bradycardia and heart block. In this case, I went with rotational atherectomy because I was able to pass it. It is a little bit, the disease is not as tight, and I can do it here. I will just go to the final picture here, and this is the final picture after using rotational atherectomy. All of this has no mortality benefit. So using rotational atherectomy and all of those devices is just to give you a way to achieve a successful PCI and to make sure that you advance and expand your stents in the best way possible. But it doesn't actually affect life expectancy of the patient. And thank you very much.